introduction. I'll be talking on infection control practices in intensive care unit. Now, the first question is why? Where is the need for the infection control practices? As you all know, prevention is primary. So I'll begin with the case. This is a 72-year-old male, Mr. XY, admitted to intensive care unit with history of upper GI bleed, past medical history of uncontrolled diabetes and CAD. After the emergent fluid resuscitation through the right internal jugular vein catheter and successful resuscitation and the management, when the patient is almost ready to be transferred out of the ICU, nurse informs you that patient has a temperature spike of 102.5 degrees Fahrenheit. Blood cultures drawn through the central and peripheral line are positive for gram-negative bacilli. You diagnose it to be CL-BSI, that is central line associated bloodstream infection. And you begin with the broad spectrum antibiotics and remove the line. This was not supposed to happen. Patients in ICU are at increased risk of healthcare associated infections. During my presentation, I'll be putting up few questions intermittently during my presentation. You can write the answers in the chat box. All the participants, all the nursing delegates in your chat box. We'll take up the answers and discussion at the end of the session. So, very basic question, define infection. Once you know what is infection, you should know what is nosocomial infection. Nosocomial infections in hospitals, this is the data from USA. The annual cost is 5 to 10 billion US dollars. Of the hospitalized patients, 5% of the admissions, they acquire nosocomial infections. And of the ICU patients, 30% acquire nosocomial infections. So this is quite a large number. By working on the infection control practices, if we cannot reduce it to zero, but our efforts should be to minimize it as far as possible. There are 1.7 million infections per year, 99,000 deaths per year. Out of these infections, 32% nosocomial are attribute infection. In UTI, 97% are catheter related. I am audible?
Yes.
Yes. So 97% are catheter related. So how important, how significant it is for all of us as the healthcare community, especially our nursing staff, to follow all the steps while inserting the urinary catheter. 22% of the infections, they attribute to SSI, skin and soft tissue infection, 15% to chest, out of which 83% are ventilator-associated pneumonias. These are again preventable. 14% to bloodstream infection, of which 87% are central line associated. So this slide is very significant. In our individual ICU setups, we have to make every effort to minimize these infections. What are the risk factors for acquiring these nosocomial infections in ICU? These patients are severely ill. They are bedridden. They have many invasive devices in the body. The number of days stay in ICU is long, and they are on many antibiotics. So they are more easily colonized by hospital flora. Usually, these are the multi-drug resistant flora. Now, how to prevent these infections? Infection control practices to reduce infection are same for all patient populations. Anywhere they are admitted in the hospital, infection control practices are the same, but the only difference between patients in ICU and ward is of the degree of vigilance. Vigilance and vigilance. This applies to other aspects also, besides infection prevention. When you are monitoring the patient, again, this is the difference why the patients are kept in ICU, for this vigilance and more attention. Now, this is a question on the screen. You can write the answer in your chat boxes. Who is not a part of infection control committee out of these? A microbiologist, a head nurse, intensivist, or endocrinologist? I move on. Active infection control program, infection control committee, infection control team, and there's designated infection control nurse. So for all the collection, tabulation, and data analysis, cooperation of all ICU personnel is needed. These are the infection control measures we'll talk about. The basic infection control practices, the standard precautions, especially the hand hygiene, then the transmission-based precautions. Preventing device-related infections, prevent antimicrobial resistance, mechanical measures, environmental cleaning, and education. This is another question on the screen. Which is not the component of standard precautions? Hand hygiene, barrier precaution, sharp protection, or N95 mask? Now, standard precautions. These require that healthcare workers assume that blood and body substances of all patients are potential sources of infection, regardless of diagnosis or presumed infection status. So when you attend to any patient in an emergency, when he has come to the hospital for the first time and you are not aware of any details, assume every patient to be highly infected and take all the precautions. Do not give any excuses to yourself or to others that I was in a hurry, I could not wear my gloves, I could not wear my mask, and I touched the patient. So be very careful. Handle blood and body substances as potentially infectious. Wash hands before and after all patient or specimen contact. So wear gloves for potential contact with blood and body substances. Wear gowns if splash with blood and body substances is possible or is expected. Wear protective eyewear and mask if splatter with blood and body substances is expected. Please use sharps in nearby impermeable container. Do not recap or manipulate. We can put it very simply that hand hygiene saves lives. This is the most simple standard precaution to prevent infection. This is the microscopic view at random taken from any nurse's hand, and you can see the bacterial growth. There are thousands of bacteria and on the hand. There are so many moments when the nurse's hand or the caregiver's hand can catch infection while changing the patient's position, while changing the patient's clothes, while taking vital signs, touching the equipment around the patient like the bedside rail, the overbed table, infusion pumps, anything and everything around the patient. Because many times staff or the caregiver feels that I have not touched the patient. So it's not just touching the hand for taking the pulse or taking the temperature or taking the blood pressure. There are so many unavoidable moments when you tend to touch the patient. So this is a pic you can see. This is in any ICU, a typical bed with the surroundings. And these are all the points where one caregiver will definitely touch. So each of this and any of these points can be a source of infection. Busier healthcare workers are less likely to wash their hands. So this is a graph. You can see the hand washing compliance goes down as the workload increases. This is the nurse attending to a patient. Now, can you find a wash basin in this picture? The location of the wash basin is such that nurse will have difficulty in accessing it and going and washing the hand there. So if they are not readily accessible, they won't be used. So location of a basin for hand washing in an intensive care unit is vital. I'm sure in all of your ICUs, for every patient, you must be having hand rub. And if you don't have, please do keep, because every time it is not possible to run to the wash basin to wash the hands. Washing hands physically with soap and water, the recommendations are when the hand is visibly soiled or contaminated with blood. Otherwise, for the basic moments when you are touching the equipment and surroundings of the patient, we can use the hand rub. Hand washing compliance. Now, how do you judge and how do you maintain the compliance? See, number of actual episodes of hand washing and number of observed opportunities for hand washing. These two are different. So there could have been 10 times when the hand washing should have been done, but it has been done only 4 or 5 times. Now, how do we advocate or how do we improve the hand washing is, one is education, teaching, like as we are having now. Having an alcoholic hand rub on each bed, making it mandatory. And to encourage your staff, the NS, ANS, or the intensivists, they all have regular meetings, classes, discussions, and in which the monthly trophies or awards are given. So hand washing compliance monthly trophy is a good, it's a good, I will say, gives a boost to the staff who are performing in ICU. Now for the transmission-based, the additional precautions. These are airborne, droplet, and contact precautions. For the airborne precautions, infections transmitted by droplet nuclei less than 5 micromillimeters, less than 5 microns. These are in the cases of tuberculosis, chickenpox, measles, aspergillus, zoster. So in this, what is important is the placement of the patient. Such patients should be kept in an individual room with adequate ventilation, preferably negative pressure room if it is available. Keep the door closed. There should be at least 6 air exchanges per hour. Exhaust has to be outside, away from the intake ducts. For the respiratory protection, the staff attending to the patient should wear a high efficiency filter mask. Limit patient transport. Transport the patient only if it is must. And if a patient has to be transported, patient should have a mask on. Then when we talk of the environmental control, ensure appropriate environmental and equipment cleaning, disinfection, and sterilization. This is isolation, where such patients need to be kept separate from the other patients. In droplet precautions, these infections are transmitted by droplets of more than 5 micron, like influenza, mumps, rubella, diphtheria. Transmission requires close contact, that is within 1 meter. For droplet precautions, again, patient placement in individual room. You need to wear a mask for the respiratory protection. Limit patient transport if needed. Place mask on the patient and ensure appropriate environmental and equipment cleaning, disinfection, and sterilization. In contact precautions, infected or colonized with microorganisms transmitted by direct or indirect contact. Example, gastrointestinal infections, wound and skin infections, and infections with MRSA. Transmission by contact, VRE, vancomycin-resistant enterococci, Clostridium difficile, herpes simplex, lice, scabies, MRSA, multidrug gram-negative resistant bacteria, chickenpox, localized zoster in immunocompetent patients, and respiratory viruses. Again, these patients need to be placed in a single room. Protective clothing and hand washing. Limit patient transport, patient care equipment, and ensure the environmental control. So this is a very sad picture, but this is how most of the busy ICUs look like. You can see all our enemies here, MRSA, Salmonella, and E. coli. Any invasive device inserted into the patient, it creates a new portal for microbes to enter. So anything put in the body has its pros also and cons also. So anything you are giving to the patient, be it in the form of any equipment or drugs, it's our duty daily to rethink and focus on which lines can be removed or which drugs can be stopped. Now, I'll talk quickly about the bundles. I'm sure most of you must be following this. It can be a quick revision, but at the same time, there is so much of heterogeneity of ICU care in our country that standardization still is a big challenge. So maybe most of you attending this might be working in good setups in corporates or big private hospitals, but every city has small setups also where things are not up to the mark. So all those who are learning here on this platform, try to disseminate your knowledge to others in your city too. So when we talk of ventilator bundle, VAP prevention measures, hand washing, elevation of head end of bed, oral care, management of oropharyngeal and tracheal secretions, daily sedation, vacation, and daily assessment of readiness to extubate. Peptic ulcer prophylaxis and DVT prophylaxis. Elevate the head of the bed by 30 to 45 degree, which reduces the chance of gastric reflux and aspiration of gastric content. Head elevation in patients, there is certain precautions in very few patients, but usually most of the patients can be kept at head and elevation of 30 to 45 degree unless you have been specifically told not to do. For a conscious patient, oral care has to be through regular brushing. See, there is colonization in the oropharynx. So normal flora gets compromised. There is colonization by microorganisms which migrate to the lower airway, which leads to VAP, ventilator-associated pneumonia. So you need to assess the oral cavity once in every shift, brush the teeth once in every shift, that is 3 times a day. For oral care, use chlorhexidine thrice a day, hypopharyngeal and subglottic suctioning at least 6 hourly, and apply mouth moisturizer as needed. Now, to minimize the risk of aspiration, maintain the ET tube or tracheostomy tube cuff pressure at desired level, usually 20 centimeters of water. Use 2 people to assist while doing the suctioning. Keep ventilator circuit free from accumulated water. Drain water away from the patient and change the suction jar every 24 hours. Or more frequent also if needed. While administering oxygen, it has to be humidified. Distilled water is used. Giving dry oxygen to patient is an offense. It's a crime. So humidified oxygen is must for any patient. Use sterile single-use suction catheter. Change the tubing every 72 hours. Change tracheostomy tube every 7 days. And empty contents of suction bottle every 4 to 6 hours. And suction bottle needs to be changed every 24 hours. Discontinuation of sedation until patient is responsive. This is to patients who are on prolonged ventilation to break the continuous sedation. Usually it's done in the morning time, and to check for the responsiveness and to assess the patient. In bloodstream infection bundle, hand hygiene tops the list everywhere. 1, hand hygiene, maximal barrier precautions, chlorhexidine skin antisepsis, optimal catheter site selection. Well, that is little debatable whether internal jugular or subclavian, but for sure femoral catheter lines are avoided. Daily review of the line with prompt removal of unnecessary lines. And when you are inserting the central line, if you are not following it, please make it a point after this presentation. Patient has to be draped with a sterile sheet from head to toe. This is the line insertion checklist. Now, measures to prevent catheter-related urinary tract infection. One, the trained personnel should always put the urinary catheter. Usually, the tendency is to give this work to the least experienced and the newcomer, thinking it to be the most trivial job. But putting in simple peripheral line intracath, putting in a urinary catheter, these are very, very important, and they play a very important role in infection prevention. Insertion has to be in aseptic technique. That's the reason patient has to be, for this also, patient has to be covered with the sterile sheet properly. Then after insertion, regular catheter care and timely appropriate removal. I'll make a quick mention of the 12 steps to prevent antimicrobial resistance. Our first aim is to prevent infection. If we are not able to prevent it, we should be able to diagnose it and treat effectively. Then use antimicrobials wisely and prevent transmission from one patient to another. So I'll talk about these 12 steps one by one in the subsequent slides. Step 1 is vaccinate. Pre-discharge influenza and pneumococcal vaccination of at-risk hospital patients and influenza vaccination of healthcare personnel will prevent infections. Get the catheters out. Catheters and other invasive devices are the #1 exogenous cause of hospital onset infections. So they need to be removed when not essential for the patient. Once infection is there, then diagnose and target effectively. Appropriate antimicrobial therapy saves life. Culture of the patient, we call it pan culture. We send the pan culture, it means culture of the urine, of the blood, and of the, depending on the source of infection, usually the chest secretions, that is the endotracheal or the tracheostomy tube. Target empiric therapy to likely pathogens and local antibiogram. Target definitive therapy to known pathogens and antimicrobial susceptibility test results. Always discuss with the infectious disease experts. I always discuss with my microbiologist. We get any report of culture, we discuss amongst ourselves. So discussion improves the outcome of serious infections. All hospitals still do not have infectious disease experts, but that time is not far. In the coming decade, I think this we'll be having these infectious disease experts too. Practice antimicrobial control. Programs to improve antimicrobial use are effective. Engage in local antimicrobial use quality improvement efforts, local antimicrobial policy, antibiotic cycling, and restrict use of high-end antimicrobials. Use your data, know your local antibiogram, know your patient population, and then decide the antibiotic. Treat infection, not colonization. So this is very important. Collection of the sample for culture again has to be in the experienced hands. A major cause of antimicrobial overuse is treatment of colonization. So treat pneumonia, not the tracheal aspirate. Treat bacteremia, not the catheter tip or hub. Treat urinary tract infection, not the indwelling catheter. Know when to say no to Venco. Vancomycin overuse promotes emergence, selection, and spread of resistant pathogens. Failure to stop unnecessary antimicrobial treatment contributes to overuse and resistance. Isolate the pathogen. Use standard infection control precautions. And we should prevent patient-to-patient spread. Break the chain of contagion. How? If you are sick, stay at home. Do not go for the duty. Take permission. Ask for leave. Keep your hands clean and set an example. Few quick lines on the pressure ulcer initiative, prevention and care. This is very, very important. You have to keep the skin clean and dry. Give back care 4-hourly. Observe the skin for any color change, warmth, or tear. Position change to the lateral, right lateral and left lateral every 2 hours. Catering to the toileting needs of the patient immediately. Don't fall prey to this habit of putting on a diaper to the patient and leaving the patient unattended. No, it's a strict no. And at the same time, providing adequate nutrition and fluids. Now, what about the mechanical measures? You have to maintain the adequate space between the beds. And ICU staffing, which is very important. Patient-nurse ratio of a patient on ventilator has to be 1:1. Whether it's a doctor in the unit or the head or the nursing staff, NS, ANS, anyone, all of us, we have to maintain this ratio and be persistent with our efforts with the administration of the hospital. There is always an ongoing tussle, but if we have to give good care, we have to prevent infection, we have to give good outcome, we have to be very, very particular. The advocate is of 1:1. Yeah, for ventilator patients, we always do. But for a non-ventilated patients, at times, most of the times, we do 1:2. While doctor-patient ratio of 1:4 is a recommendation, but it is practically not possible to follow it. One doctor usually sees 10 to 12 patients and at times more also. But I don't think this is much of an issue, because in COVID, we have seen how all the healthcare workers, we have given our services in those overwhelming situations. So disinfect items of daily use, your pens, cell phones, computers, stethoscopes. Leave them in the unit. Do not take them home. That's the best thing. Now another question. Define disinfection. Define sterilization. You can keep the answer in your mind, and at the end, I'm coming to end in next 5 minutes. Then we can have the answers by hand raising. Cleaning and disinfection of ICU is very important. Wash floors, walls, ceilings with soap and water. Use hard brush, let it dry. Clean beds, furniture, fans with soft clothes soaked in disinfectant. Let it dry for 15 to 30 minutes. Clean ventilators. And once the bed is vacant and that bed has been thoroughly cleaned, you need to wait for minimum of 2 hours, preferably 4 hours, before another patient is taken on that bed. One question comes up on your screen. Which amongst the following requires only cleaning? Floor in ICU, walls, windows, or all of the above? So when we talk of infection control practices, education has proved to be the most effective measure. It can be in the form of classroom teaching, while taking morning rounds, the major rounds, Nukkad concept, posters, and educate the staff and relatives of the patient too. Other measures are taking care of the employee health by the organization who employs us. Multiple dose containers to be avoided, reuse of single-use devices, linen, monitoring sterile supply, cleaning and disinfection of articles, and monitoring of disinfectants. We need to integrate these measures into our behavior. ICU staff needs to take up ownership. Like I always tell my staff and my doctors in the unit, कि ICU का गुंडा कौन है? So take ownership. And when you are right, nobody will say anything against you, because bedside nursing staff is the most important person in our ICU setting. So it's world over, such articles keep coming up. Hospitals cure, but also infect patients. So we need to incorporate new evidence-based practices, improve application of these strategies in clinical practice, and better understanding of degree of implementation and reasons for barriers to implement. Thank you.
Thank you, Dr. Diptimala, for such a vast, wonderful, and very well explained presentation on this very important topic. So, from the audience, any questions? So I think if I try to revise your presentation,
Yes.
you have covered about the prevention of the infection, which is basically caused by our healthcare workers also. Our nursing staff is the main backbone of our hospital, and they are the main person who can give us very good result or very bad results also. Because they are in direct contact with the patient, I always advise them to just stand with the patient for 3 minutes. 3 minutes are more than enough. And just observe the patient from top to bottom, head to toe, and just see what are the articles and what are the things which can infect the patient. You will definitely come to know what are the invasive things, what are the outside things which are standing near the patient, what are the people who are coming to the patient, touching the patient and spreading infection, be it your food giver or a physiotherapist or Aya nurse, Aya, or these fourth class employees who are doing their important works like stool cleaning and all. They are actually more important to take care. What happens usually, some physiotherapist or food person comes from canteen, they touch the patient and nobody takes care how they are touching the patient. So we have to take care of these people also who are coming in the ICU and giving the infection. I think there's some question.
I think all the participants, you can ask. Now, one question. Yes, ma'am, you can read that question.
The question is usage of distilled water in oxygen flow meters. So many pulmonologists and senior intensivists don't allow. Please give your valuable input, madam.
So this is a question from Balaji Vadi. So,
Yeah.
So Balaji, you can unmute yourself and you can come on screen. Put your video on and unmute. Okay, he cannot be unmuted. Okay. Okay. They can just listen to us. So I just wanted to ask, when they are not recommending distilled water, what are they recommending? Then I'll be able to answer it. Dr. Vandana, are you using something else?
No, we are using distilled water only.
Yeah, even we are using distilled water. So if Balaji could type that, what do these other pulmonologists and intensivists, they recommend? No additives.
No additives. Then how do you clean the catheter? You have to clean the catheter, then use it. I mean, the catheter, suction catheter is used once only, but for one time also you have to put it in again and again, two, 3 times at least. Then you discard it.
He's asking about the distilled water in the oxygen flow meter. So Balaji, we use distilled water. If any new recommendations have come up, yeah, about oxygen flow meter, I read that. We need to look up. I'm not aware. If you can just type in the chat box, what is advised by the pulmonologist at your center? Somebody has typed the answer. Oxygen only, madam. Nothing else.
It will be dry oxygen.
No, there is still advocation of
there must be some
humidified. It has to be humidified oxygen.
No, dry oxygen is not preferred unless it is being humidified from the source only.
Yeah. Balaji, what you can do is you can take my mobile number, right? I'll put it in the chat box, and on WhatsApp we can discuss this. Okay. Any other questions? Achha, I am typing. What I believe in is when we work in ICU, our duty is to disseminate this knowledge of the basics, not only to our doctor colleagues and not only to our nurses, but to the public also. So for public awareness, I have a YouTube channel. All those who are interested, they can subscribe and they can share with their family and friends. It can save many lives. Any other questions? Vandana ma'am?
No, right now I think there's no other question. So, Dr. Deepti, can you tell something about biofilms and how can we avoid the biofilm problems?
How can we avoid biofilms?
Yeah.
Again, everything comes back to the basics of the it's very difficult to avoid because most of us are in a tertiary care centers. So very few of the patients are fresh admissions. Usually the patients who come to intensive care units, they have been hospitalized already for days or weeks together, or they have been in other ICUs and they have had exposure to many antibiotics random use without any evidence, without any cultures. So all these things, they create these problems. But yeah, if we receive a prima facie, a fresh patient, and our choice of antibiotics is, I will say, based on the history and where the source of infection, I'll say more scientific and more logical. So in those patients, this can be minimized or these can be avoided.
Yeah,
What
plus and what I think is we can avoid this also by frequently changing the lines. Like we all have the protocols of changing the Foley's catheter. If it is rubber, is in 7 days, ET tube in 7 days.
Huh.
One more question I wanted to discuss with you is how effective it is to change the ET tube after 7 days. I mean, we are planning a tracheostomy, and we think we can avoid the tracheostomy too. So what we do is we just change the ET tube. But do you have any idea how much will it be effective for prevention of infection just to changing the ET tube?
See, any patient in which we are anticipating prolonged ventilation, then just changing of endotracheal tube and going in for a tracheostomy, the basic purpose is that the oral airway gets cleared. It is without any device in it, and we can give good care. So after 7 days, just changing of the endotracheal tube, it will be just one step to prevent it from it getting blocked. That's all. Otherwise, from infection perspective, it won't be very helpful. Patient will need a track, and we should go for it. Any patient who is salvageable, and we should go for a track. I would advise that.
That means you suggest early tracheostomy, right?
Early tracheostomy. Yeah.
And they say that tracheostomy should also be changed every 7 days.
Yeah,
My personal experience is first changing of tracheostomy tube should be after 15 days. Because what happens if we change the tracheostomy tube earlier, there are chances of making false route, false canal to the this thing, trachea. Because in 15 days, the track is completely healed and the track is formed. So first changing the tracheostomy tube, if we do it after 15 days, we are sure that the track is already formed and we are not going to make a false track.
This is most of the places, like we do percutaneous tracheostomy. So while changing, we can put in the guide wire.
Yeah.
After 7 days, we do it after 7 days.
Okay.
So if there is any doubt, we can put in a guide wire, take out the tracheostomy tube and put it over that. So I will recommend after 15 days, we change it after 7 days.
Okay.
Yeah.
Any other questions from anybody? I think 2 questions are there. No. So I think if we summarize the whole topic, I have written few points. Most effective is hand hygiene. Then we have to take care of respiratory or cough hygiene. I mean, how to prevent the spread of aerosols. Then cleaning is very important. Cleaning the environment and cleaning the patient is equally important. Then toileting and sanitization of the things related to patient. Then personal PPE, safe management of environment, then linen, etc. We are throwing the linens in ICU. That is very bad. Always the store dumping area should be very far away from the ICU. Then safe management of blood, body or fluid, blood or body fluids. Then safe management of waste of the patient. and prevention of exposure of infection, like many, and there should be least crowding in the ICU also. These are the few things if we take care of. And what I personally feel is we should always stick to the protocols. Protocols are made after a lot of journey through the patients and complications. So once we follow the protocols, there are chances that we are going to have least infections. Thank you, Dr. Diptimala, for such a nice explanation.
Thank you so much. It's been my pleasure. I hope all those who have attended have benefited. And if many would be shy to ask questions, so I have put in my mobile number. You can ask me on WhatsApp. I'll be more than happy to answer. Thank you.
Thank you.